Good, good evening, colleagues. Welcome to Endoscopy Now and today's virtual education program, Endobariatrics and Bariatric Surgery, Management of Obesity in the Future. I am Barham Abudaya, Professor of Medicine at the Mayo Clinic in Rochester, Minnesota, and I will be your moderator today. I'm pleased to introduce the speakers for today's webinar. Dr. Sai Jarapino, who is the Associate Director of Bariatric Endoscopy and Director of Bariatric Endoscopy Fellowship at the Brigham and Women's Hospital in Boston, Massachusetts, and Dr. Lena Ketan, who is the Director of Bariatric Surgery and Esophageal and Swallowing Disorder Centers at the University Hospital in Cleveland, Ohio. Welcome, Sai and Lena, and thank you for joining us. We'll start with Dr. Jarapino giving us Endobariatrics 2023 updates, and then we'll go to Dr. Ketan. Sai, the floor is yours.
Thank you so much, Dr. Abudaye, and I'd like to thank AFS and Endoscopy Now for the invitation. I'm very excited today to talk about a topic that is dear to my heart on Endobariatrics 2023. Here are my disclosures. So the goal today is to review the currently available primary endoscopic bariatric and metabolic therapies, or EBMTs, and also endoscopic treatment of weight regain following bariatric surgery. We're going to start with primary EBMTs. In 2023, when we talk about bariatric endoscopy, we currently have 4 endoscopic devices and/or procedures that are FDA cleared or approved and available in the United States. These are Obera intragastric balloon, ESG or endoscopic sleeve gastroplasty, POSE, and Endomina. For ESG, POSE, and Endomina, this essentially refers to when you use an endoscopic suturing or plication device to reduce the gastric volume along the greater curvature by about 70%. As you can see on the right column, with intragastric balloon, the weight loss is about 10 to 12% at 1 year. For ESG, POSE, and Endomina, the amount of weight loss is about 15 to 18% at 1 year. For today's talk, we're going to be discussing ESG and POSE, which have more data. So let's start with ESG. This is when we use an endoscopic suturing device to reduce the gastric volume along the greater curvature. This device is commercially available widely. The device is mounted on a double-channel endoscope. Initially, this endoscopic suturing device was cleared by the FDA for tissue approximation in 2008. As of last year, this device received de novo marketing authorization from the FDA for the treatment of obesity and weight regain. Additionally, there's another version of this device where you can mount it on a single-channel endoscope. This device is cleared by the FDA for tissue approximation. So if you talk to 10 bariatric endoscopists on how they perform ESG, you're going to get 10 answers. Here's how we currently perform ESG at our institution. As you can see, we start at the incisor. Here, I use the tissue helix to pull the tissue into the suturing device, starting at the anterior wall. After that, we're going to start coming down along the greater curvature and end at the posterior wall. So the first suture is the running suture pattern. So the goal for this first suture is to reduce the gastric width at the incisor area, as you can see here. After that, we're going to start the second suture slightly more proximal to the first suture, again at the anterior wall. And now we're going to move down along the greater curvature and come down to the posterior wall. However, for the second suture, we're going to be doing a U suture pattern as shown here. So I'm moving up proximally along the posterior wall and then start suturing up along the greater curvature and then end on the anterior wall. If you look on the picture on the left, this is the U or the yellow line on the left. So the goal for the U pattern is to reduce the width, but also shorten the stomach at the same time. All right, and now we're going to be cinching the second suture here, and you can see that the stomach is being reduced by both width and length. After that, the third suture is going to be an interrupted suture pattern where you place the first stitch on the anterior wall and then the second stitch on the posterior wall. And the goal is to further reduce the width of the stomach. After that, you just repeat the U and interrupted pattern and move up proximally. And this is the final look of the endoscopic sleeve gastroplasty. All right, so what's the data on ESG? Here's the pivotal trial led by Barham Abudaye called the MERIT trial. It's an RCT of 208 patients who were randomized to ESG versus moderate lifestyle modification. As you can see, the amount of weight loss was 13.6% in the ESG group compared to 0.8% in the lifestyle group. Additionally, after 1 year, they crossed over the patients who were in the control group and they got ESG at 1 year and followed them for 1 more year. So at 2 years, both groups experienced similar amount of weight loss. So how does ESG work mechanistically? Here's a sub-study of the MERIT trial looking at 36 patients. 18 of them underwent ESG and 18 underwent lifestyle modification. What they found was that ESG was associated with a delay in gastric emptying at both 3 months and 12 months, as shown on the graph on the right. Additionally, greater delay in gastric emptying at 3 months appeared to be associated with greater weight loss at 1 year. Furthermore, when they looked at gut hormones, at 18 months, fasting ghrelin, GLP-1, and PYY significantly increased compared to baseline for patients who underwent ESG. And just a quick reminder, GLP-1 and PYY are satiety hormones. Therefore, an increase in GLP-1 and PYY means that patients feel full sooner. For ghrelin, this hormone makes you feel hungry. However, this is the effect of weight loss. For example, when the body has a lot of weight loss, ghrelin goes up as a consequence. So all of the changes in gut hormones here are good changes for ESG group. So what about in terms of real-world experience? This is a meta-analysis of 8 observational studies looking at 1,700 patients who underwent ESG. The meta-analysis found that the amount of weight loss was 16.5% total weight loss at 1 year. The pooled SAE rate was 2.2%, including pain, nausea, GI bleeding, leak, or fluid collection. What about durability of ESG? Here's a single-center study from Reem Sharaya. She looked at her patients, 216 patients. Of these, 38 patients were due for a 5-year follow-up, and the follow-up rate was 82% at 5 years. What they found was that the amount of weight loss at 5 years were maintained at 15.9% total weight loss. All right, so now we're going to switch gears and look at plication ESG or post-procedure. This procedure refers to when you use an endoscopic plication device, which is cleared by the FDA for tissue approximation, to reduce the gastric volume by about 70%. Right now, the procedure is undergoing a U.S. pivotal study led by Dr. Barham Abudaye. The device is also commercially available at limited centers. Here's how we use the device. Here you can see that we use a tissue helix to pull the tissue in into the approximation device. We then pass the needle and drop the first tissue anchor. After that, we drop the second tissue anchor and cinch the tissue together. The suture is then cut and released. Traditionally, the post-procedure involved placing plications in the gastric fundus. However, in 2018, our group reported a new technique called distal post, where plications are placed primarily in the gastric body, sparing the fundus. From a mechanism standpoint, here's a study from Spain looking at 18 patients who underwent traditional post. What they found was that post was associated with a delay in gastric emptying. Additionally, there was a greater drop in the ghrelin level and a greater increase in postprandial PYY after post. And just a reminder, this essentially means that after eating, patients felt much less hungry after post and felt much fuller after the procedure compared to prior to the procedure. All right, so this is how we currently perform the post-procedure. We call it a double helix technique. As you can see, again, we start at the insosor, but we use 2 tissue helixes to pull the tissue into the approximation device, drop the first tissue anchor and second tissue anchor. And now we're cinching both tissue anchors together, sutures and cut and release. And you can see that the width of the stomach is significantly reduced with only 1 plication. After that, we start moving up into the gastric body and place more plications to reduce the width and also length of the stomach. So what's the data for post? Here's a single center study from our group looking at 110 patients. At 1 year, patients experienced 15.8% total weight loss. There was 1 SAE, including a gastric perforation case. Additionally, when we did a subgroup analysis, we found that patients who underwent a distal post using a double helix technique experienced more weight loss compared to a single helix technique, 20.3% total weight loss compared to 13.4% total weight loss. Additionally, 95% of the double helix group experienced at least 10% total weight loss compared to 58% at 1 year. Furthermore, we look at comorbidities and found that following post, there were significant improvements in blood pressure, hemoglobin A1C, HOMA-IR, and AST/ALT. What about fatty liver? Here's a study from our group looking at 45 patients with obesity and NAFLD and F2 to F4 fibrosis. All patients underwent the post-procedure. What we found was that there was a significant improvement in non-invasive tests for hepatic fibrosis. Specifically, ALT went from 50 down to 24. There were significant improvements in NFS and FIB-4 score. And on FibroScan, liver stiffness score went from 13.9 down to 8.9 kilopascal. At 1 year, patients experienced 15.5% total weight loss. All right, so now we're going to shift gears and talk about endoscopic management of weight regain following bariatric surgeries. So how common is weight regain following Roux-en-Y gastric bypass? Here's an observational prospective study published in New England Journal about 5 years ago now, looking at 1,100 patients. Of these, about 400 patients underwent Roux-en-Y gastric bypass. What they found was that at 12 years following the surgery, Roux-en-Y patients regained about 20% of the weight they initially lost. Additionally, about a third regained about almost all of the weight they initially lost. So what causes weight regain? Here's a study from Barham Abudaye and Chris Thompson. And what they found was that the size of the outlet or gastrojejunal anastomosis is associated with weight regain. As you can see on the graph, the y-axis represents the amount of weight regain and the x-axis represents the size or the diameter of the gastrojejunal anastomosis. And there is a positive correlation between the two. So this is the concept of how we can treat or revise Roux-en-Y gastric bypass. Essentially, we can do this using either an endoscopic suturing device or plication device to sew and plicate and reduce the diameter of the gastrojejunal anastomosis. So let's start with the suturing transoral outlet reduction or STOR. So does it matter how we sew? The answer is yes. This is a study from our group comparing purse string suturing technique versus interrupted suture technique for performing TOR. As you can see, at 1 year, purse string group experienced 8.6% total weight loss compared to 6.4% in the interrupted TOR. What about long-term data? Here's a study from our group looking at 331 patients who underwent TOR. 123 patients were eligible for a 5-year follow-up, and the follow-up rate was 83% at 5 years. The efficacy at 5 years was 8.8% total weight loss, and 62% of the patients were able to maintain at least 5% total weight loss. All right, so how do we perform TOR now? This is our current technique at performing endoscopic revision of gastric bypass. So we use a modified ESD TOR technique. As you can see here, I use a hybrid knife to inject and also incise the mucosa layer around the gastrojejunal anastomosis. And once you go around the circle, you can do some cutting and also some injection to widen the submucosal layer. After that, we're going to perform APC on the inner rim and also outer rim of the exposed submucosal layer. And here we use force APC and 71s. After that, we're going to start performing purse string suturing. Again, we start at the 5 o'clock position, and you want to sew so that the needle comes out at the exposed submucosal layer or the blue area here. And then you start sewing in circle, going in the counterclockwise fashion. And the goal is to place at least 12 stitches around the outlet. And here you can see that it's very easy to see staples. So when you do the ESD technique, you can avoid sewing into the staples. So after we're done with the purse string TOR, you can cinch it around a 7mm CRE balloon. So you can see that the size of the gastrojejunal anastomosis is significantly reduced with the procedure. So what's the data for ESD TOR? Here's a small study from our group looking at ESD TOR compared to the traditional APC TOR. And what we found was that at 1 year, the ESD TOR group experienced more weight loss, 12.1% total weight loss compared to 7.5% total weight loss in the APC group. All right, let's move on to plication TOR, or a procedure also known as ROAS. So this is how we perform the procedure. We start by performing APC around the gastrojejunal anastomosis. After that, we use the plication device to place plications around the outlet to reduce its diameter as shown here. After that, you can place a few more plication in the pouch, and the goal is to reduce the volume and also length of the pouch. So this is a study from our group looking at 110 patients with Roux-en-Y who underwent the ROAS procedure. At 1 year, patients experienced 9.5% total weight loss. There were no SAEs. The rate of GJA stenosis was 9.9% in this series. All patients responded to CRE balloon dilation plus minus lamb stem placement. So now you may wonder, how do we choose which procedure to offer for patients with weight regain? This is the algorithm that we use at our institution. So you start by looking at the pouch length. If the pouch is short, less than 5 centimeters, you can do either APC or suturing. It is too small to do a plication procedure. After that, you look at the outlet size. If the outlet is less than 18 millimeters, APC or suturing TOR results in similar weight loss, so you can offer either or. However, if the outlet is at least 18 millimeters or greater, suturing TOR results in more weight loss compared to APC. Now, if the pouch is longer than 5 centimeters, you can choose between suturing TOR or plication TOR. You then look at the outlet size. If the outlet is smaller than 25 millimeters, plication TOR or ROAS results in greater weight loss and should be considered. However, if the outlet is greater than 25 millimeters, suturing TOR results in greater weight loss and should be offered. All right, and last but not least, like we hear a lot of news about the injectable GLP-1 receptor agonist, so combination therapy is getting more and more popular. So here's a study looking at combination therapy for TOR. We looked at 145 patients, Roux-en-Y, had weight regain who underwent combination therapy. In this study, we defined combination therapy as initiation of an anti-obesity medication within 6 months prior to or after TOR. In this series, the most commonly prescribed medications were topiramate, phentope, phentermine, and followed by liraglutide. At 1 year, patients who underwent combination therapy experienced 15.2% total weight loss. Additionally, when you compare it to monotherapy, we found that combination therapy results in greater weight loss compared to medication alone or TOR alone. Additionally, the amount of weight loss of combination therapy is similar to surgical revision. However, if we look at SAE rate, the combination therapy had a similar SAE rate compared to pharmacotherapy alone or TOR alone, and this is lower than surgical revision. In conclusion, endoscopic bariatric and metabolic therapies are safe and effective at treating obesity and metabolic diseases. EBMTs may be divided into primary EBMTs, including balloon, ESG, and POSE, and endoscopic management of bariatric surgical complications, including weight regain. EBMTs should be offered in a multidisciplinary care team model. And last but not least, future of endobariatrics includes personalized therapy and combination therapy. Thank you very much, and I'm happy to take any questions.
Thank you, Dr. Jarapino, for this fantastic lecture and overview of endobariatrics in 2023. Now we will shift to Dr. Ketan to give us an update on bariatric surgery, current state, and future outlook. Lena, the floor is yours.
Thank you so much. And I really would like to thank Endoscopy Now and AFS for the opportunity to be here with you this evening. So let me share my screen. Can you all see my screen okay?
Yes, we could see your screen, Lena.
Okay, great. And then I'll go ahead and start the slideshow there. So again, thank you so much for the privilege of being here tonight. And so we're going to talk a little bit about surgery. So Dr. Jarapino's presentation was phenomenal, and the work that they're doing at the Brigham is over the top. But hopefully I can share a little bit of a surgical perspective. And over the next 20 minutes, we'll talk about the obesity crisis, the diseases that relate to obesity, what are surgical management options along with their effects and durability. We'll talk a little bit about revisions, the future of this disease, and then how can we affect change, taking a little bit of a different perspective than Sai took. So we all know that obesity is obviously, it is the new pandemic, right? It affects 39% of our patients here in Ohio, actually over 30. In 2018, it was 34%. In 23, it's at 39%. And the number just keeps growing. So this is a pandemic that's affecting more of our population than any other disease in America. And the scary thing is it's really affecting our children. Almost 20% of children in America are obese. And so this is our future. And the scary thing is kids are getting high blood pressure, high cholesterol, type 2 diabetes, having breathing problems, sleep apnea, joint problems. And these are problems that a pediatrician never even had to think about. So, we really have a changing population. Obesity has reached epidemic proportions. I always like to share this USA Today headline. This is from actually 2007, saying that obesity in America is worse than ever. And 6 out of 10 are overweight. So that's a BMI over 30. And like I said, over a third of Americans are obese. And so it just so happened when I had relocated here to Ohio from Atlanta, Geauga County at that time, this was in 2007, had been identified as the most obese county in the United States, and that's where we started a new bariatric program here. We also know that obesity costs us a lot of money. $190 billion a year is the estimated annual healthcare cost of obesity-related illnesses. And Americans who are overweight or obese spend at least $700 more a year on medical bills. And with our rising co-pays and deductibles, this is getting even higher. So this is costing us a lot of money. And the scariest thing is that our life expectancy is going down, so that we're the first generation where life expectancy is actually decreasing rather than increasing. And we know from some of the work that's been done that overweight children also become overweight and obese adults. We know obesity causes a lot of problems: pulmonary disease, fatty liver, coronary artery disease, cancer, gynecologic abnormalities. And honestly, these are all the health problems that are driving our health system and economically right now. But the underlying problem for so many of them is still obesity. And it's a part of a lot of our society guidelines. And I think that this is the pop health kind of perspective to take on this, that, we have so many, basically every society has recognized that to manage whatever disease they care for, whether it be diabetes, joint pain, heart disease, whatever, that weight is a factor to address. And then if any of you ever has time, I recommend reading this JAMA article from 2018 that is dedicated to obesity care and has 5 randomized trials. I really recognized obesity as a huge problem, and what they took away from these randomized trials is why people are obese. And I'll share with you why I'm kind of going through some of this background here in just a moment, when I'm supposed to be focusing on surgery. But really their take homes were, one, we need to reduce total caloric intake, and with all the processed foods out there, we know those are encouraging people to eat a lot more calories than they would if they ate less processed food. And the other thing that came out of it is that obesity management needs to be individualized, that we really need to find a sustainable approach for each patient. And I think that's what we're really talking here about tonight, is that we need to individualize care for patients who are overweight and obese, and that we know that the reason there are so many weight loss programs out there is because everybody's weight loss journey is different. And so that we need to personalize that. And that's why it's so important that we have the endoscopic therapies that Sai shared with you, as well as the surgeries that I'm going to talk to you about here. So let's talk about effectiveness. You heard a lot about the endoscopic therapies, and there's definitely a lot of merit to the primary endoscopic therapies, and then using endoscopy for a lot of our revisions is actually something I like to use in my own practice too. But we do know that weight loss surgery has been proven to show 50 to 80% sustained total body weight loss for at least 20 years. The most important thing that we see is the improvement in comorbidities, reduction in medications, fewer physician visits, less time off work, fewer disability claims, and then lower mortality in those patients who do have surgical weight loss. And the indications that we use for weight loss surgery today are the same that we used back in the 90s when the NIH first described the indications for weight loss surgery with a BMI over 35 with comorbidities or BMI over 40. I think what we're learning now is that even that 30 to 35 group who does have comorbidities, particularly something like diabetes, could merit from weight loss surgery. So surgery definitely has durability, and that's what separates it from a lot of the other weight loss methods out there. Now, I know Sai shared with you a lot of data from ESG, and honestly, a lot of the early data is very, very promising. So I think that, this is going to be in our armamentarium for a very, very long time. But obviously, it's going to take a long time to get to that 20-year data that we have here today for weight loss surgery. And this data primarily comes from this long-term data from a Swedish obesity study, where they took a group of patients who were morbidly obese and looked at a control group that was treated with diet and exercise alone, and then looked at the patients who had the various treatments, gastric bypass, and the restrictive procedures at the time, BBG and banding, both of which are essentially restrictive procedures we don't do much anymore. What we do is we alter those to other procedures, but the sleeve is really the restrictive procedure, surgical procedure of choice, the surgical vertical sleeve gastrectomy, and it's somewhere here in the VBG a little bit more, but definitely because it's restrictive only does not achieve the weight loss we see with the gastric bypass. But what this graph shows is that there is well-established data showing that when you use a combination malabsorptive and restrictive procedure, that you are going to have sustained weight loss going out 15 to 20 years. Even with the restrictive only procedures, you're not going to lose as much weight, but the weight loss is sustained. And I think that's really, really important to take home. And so from that same study, this is a graph going out 20 years, now taking all those surgical groups and collapsing them down into just a surgical group versus that control group. And on the y-axis, you see BMIs here, and you can see even out to 20 years, regardless of whether they had a restrictive only or a combined procedure with malabsorption and restriction, that they have sustained weight loss going out 20 years. And then you can see the results of all the patients, and you can see that the blue dots represent the controls, those who had diet and exercise alone, and the yellow dots are the surgical patients. And you can see many of them stay below a BMI of 30 who are in the surgical group, but you see very few blue dots down in this region. And I think that the take-home message is that surgery works, and it's durable, and it's effective. And how do we know how effective it is? Well, life expectancy. Okay, when we look at life expectancy in this study now at years of follow-up and extrapolated out to 40 years, but we can see even at the 30-year mark that there's at least an increase in life expectancy by 3 years for all comers who have surgery compared to those who have no surgical intervention for their weight loss. So this is a really big deal. I mean, there's very few cancer trials where you can say that you've extended somebody's life by 3 years, right? But this is what we can do with surgery for obesity. And I think that this is really, this is what makes me enjoy what I do every day, and know that we can help people not only live longer lives, but also have an improved quality of life. And the quality of life is improved because their comorbidities are improved, their diabetes, their hypertension, their hyperlipidemia, their sleep apnea. In the majority of patients, almost all patients, it's improved. But I think the bigger take home is it's resolved in almost 3/4 of patients when you look at diabetes, hypertension, sleep apnea. And this is really, really important messaging for us to share with our patients, because I think starting to share with our patients that they need to take some more accountability, and it's not just the procedure to help them get to their weight loss goals, because it will make them healthier, is important. Just the two of the most common procedures that we do for weight loss, the gastric bypass, where this is restrictive, malabsorptive, and then I also think that it is also behavioral, in that it tells us that, I tell my patients that dumping is actually a benefit, so that if you eat those sweet, creamy foods, if you eat hard carb foods, you're going to feel really sick, and that's a benefit for our patients. The sleeve gastrectomy is now the restricted procedure of choice, and this is where we obviously do a vertical sleeve gastrectomy, removing 80 to 90% of the stomach. We're learning a lot about the fact that when we do our sleeves, that how we make our sleeves and the morphology of our sleeves is really important. It's not just about cutting away part of the stomach, but it's also very much about what you leave behind. That has a lot to do with the patient's weight loss, as well as their risk of complications such as GERD. So that if you leave a narrowing at the incisura, if you leave them with a hiatal hernia, if you leave the sleeve too big, if you make it too tight, all of those can lead to adverse outcomes. So we're really looking for a nice tubularized stomach with kind of a more lower pouch that looks more like a hockey stick at the end. Now let's talk a little bit about revisional surgery. You just heard a lot about the endoscopic procedures, and honestly, and I'm going to focus on revisional surgery for weight regain. There's reasons to do revisional surgery for a lot of reasons, but I think what we're really focused on here tonight is weight regain, and that's what I'm going to focus on in these slides. And so, when we talk about what are some of the procedures, one nice reference is this from the ASMBS revision task force that was published back in 2014 and led by Dr. Breathauer. And so when they defined the various revisional options for bypass, what they identified as things that were revisable was making a smaller pouch, lengthening the biliopancreatic limb, which is something that we're learning a lot about. People have different small bowel limb lengths. And so leaving at least 150 to 200 centimeters of common channel, leaving your Bru limb 75 to 100 centimeters, but making that BP limb as long as you can may have the greatest effect on insulin metabolism and diabetes improvement. You could also convert this to a DS. People have talked about banding at the gastrojejunectomy, but I would say in 2023, that's really not played out. I think one of the most interesting findings is in that Swedish obesity study that I've referenced a few times. If you look at gastric bypass revisions over 26 years, they identified only a 7% revision rate, which is extremely small, right? This is what killed the gastric banding, is that 30 to 40% of patients were needing some sort of a revision. That's why we rarely do the gastric adjustable gastric banding anymore. But the revision rate with bypasses is extremely low. And if they are going to happen, most of them happen within the first 10 years. And I think that's an important take home. Well, what are our options for revising a sleeve? We're talking about surgical options. One, you can convert it to a bypass, and many of the patients will lose about 20 to 30 pounds, some maybe as high as 40 or so. But I do tell patients that this is not going to be like a huge weight loss endeavor, but it is going to improve their weight loss somewhat. You can convert it to a biliopancreatic diversion or a DS, or you have all the SADI variants that are out there. And there's a lot of pluses and minuses to each of them. There's definitely been a known higher incident rate of postoperative complications with conversion to something like a DS. But with the single anastomosis, we're finding some of that might be better, but you don't want the BMI to be too high when you're converting that sleeve to a SADI. And also, if we convert a sleeve to a bypass, we're seeing that it is much better for those diabetics who do relapse. And we also see improvement in their hypertension and cholesterol control when they're converted to a bypass. So there are definitely a lot of surgical revision options, but when you compare these to the endoscopic options that you heard about, obviously the surgical revision options are far more invasive. And so, are you going to get as much weight loss with an endoscopic revision as you will with a surgical revision? Maybe not with just endoscopy or surgery, but when we start to add in medications and start multidisciplinary care, then maybe the lesser invasive along with medications might be similar. So, oops, sorry about that. I don't know how that happened. Okay. And I think the other take home is that sleeves have, in some reports, greater than 20% revision rates, as we're seeing more and more recent studies. Now, my personal take is that we're going to see a lot fewer revisions with the sleeves done from like 2017 on versus the ones done from the first decade of sleeves from 2007 to 2017, because I think we've learned a lot about how important that morphology is and how important it is to make a good sleeve. So I think as we make better sleeves, this revision rate will go down, but nonetheless, it's at least twice as high as a gastric bypass. And I think that's something to keep in mind. So taking all of this into account, what is the future of surgical care of obesity? Well, a reality is by 2030, 50% of our population is predicted to be overweight or obese. So obese, not even just overweight, obese. So that's a pretty scary number. Okay, right now we're doing about 300,000 weight loss surgeries This doesn't include the endoscopic procedures, and this accounts for less than 1% of the population that qualifies. So there are a lot of people getting surgery, but there's a lot of people not getting surgery. So I think surgery has a place to stay because it is durable, it is effective. We are showing prolonged life, and we are showing that we can do it safely. It's one of the safest operations that we do in 2023. And now with the added addition of multimodal care, thinking about using anti-obesity medications as neoadjuvant and adjuvant therapy. We'll be presenting on some of this at ASMBS next week and sharing with you some of our data showing that even particularly with the GLP-1s that we are seeing significant weight loss with both our primary weight loss procedures as well as our revisions. So I think that in the future of obesity care, first of all, we got to slow the pandemic. We really got to change people's thinking and focusing on wellness. We need to help patients recognize that the obesity is the underlying problem with their heart disease and their diabetes and sleep apnea, and not just try to treat the health problems, but go to the underlying cause, so that with using lifestyle medicine, we just reduce the incidence of obesity. But until we get there, tailoring treatment, I think, is going to be very important because we know that everybody loses weight differently. People have different coverages for procedures. And we're really learning that multimodal care, combining medications, endoscopic options, lifestyle changes, tailored diets, and tailored procedures is really going to give our patients the best outcome. And we want to give our patients the tools that they can maximize losing weight, because it's really hard for our providers to have the conversation to promote weight loss. So let's explore all our comprehensive options. Just sharing a couple of my patients. This is a patient who ran a marathon a year after a weight loss surgery. This is the only patient picture this patient could find of herself before surgery. And this is what she looked like 2 years later. So these surgeries really have a huge impact on patients' lives, not only from a health-wise, physically and mentally, because you imagine that they feel a lot better about themselves when they look in the mirror. So with that, I appreciate all your attention, and we're happy to take any questions.
Thank you, Dr. Ketan. That was a fantastic lecture underscoring that bariatric surgery does save life. And thank you for guiding us through the current available surgeries and the future. Now we will open the session for questions and answers. We have about 15 minutes for those. I could see already a couple of questions in the chat. We will address these for sure. Please provide your questions in the chat box in the question and answer tab, and we will address them as we go. We're planning to end at time at the end of the hour as well. I know Dr. Ketan has other obligations, so we'll start with her portion of the questions and answers so we could relieve her to attend to her obligations. So, Dr. Ketan, we have a couple of questions for you. The first one is, you illustrated the benefit of bariatric surgery, and there's plenty of them. Clearly, the best is improved morbidity and mortality over the long term, as you alluded. But the fact of the matter is about 1% of patients are getting the surgeries because of multiple barriers, and we could highlight them. So how do you see the evolution of pharmacotherapies, endoscopic therapies, fitting in the spectrum to increase this access? So we go from 1% of patients getting effective therapeutics to now hopefully 10% or 20% down the line. And how do you see that we segment the populations in order to also be cognizant with the health economic story? Obviously, if we're going to treat 2/3 of the population, that's a significant burden on the healthcare system as well. So how do you see the future of segmentation of the population and how all these interventions are going to mesh together?
Yeah, thank you, Barham, and I really appreciate the question. And you know, it's so there's a lot that goes into the question that you asked. But I think first of all, I think that surgery has been scary for a lot of patients. And every patient you talk to has heard a bad story. Now, they haven't heard 300,000 bad stories, but once they hear that one bad story, they're like scared of it, right? Even though we know that because of all the centers of excellence that we have, our complication rates are less than 1%. But I do think that what obesity medications and endoscopic therapies bring to the table are alternatives for patients to lose weight. And I think that the big question with these is going to be the durability, because we are learning that the anti-obesity medications are effective and they do great, but we also are learning that if you stop using them, then you regain the weight. So then, I think that what the medications will do a couple things. One, it will help people realize that they actually like being at a lower weight, and they're going to say, okay, I like being lower weight. Surgery was scary for me. I was able to achieve it. Now I want something durable, and so I think that will actually provide a pathway for some people looking for that durability, particularly if the cost of medications remains prohibitive and not covered by many health plans. As you said, there are a lot of barriers. The same with the endoscopic therapies. A lot of the endoscopic therapies that are out there are, we haven't proven durability yet. And we're really looking for durability, particularly with the ESG. But, I think that's the endoscopic procedure that's shown the most promise with durability, and then easy kind of redos of it, because you can always go back and put a couple extra stitches. But I think, we've also seen that going back and putting a couple extra stitches isn't as easy as everybody thinks. And it does carry with it some risks as well. Right now, these procedures are being done with experts like yourself. And as it gains wider popularity, we are going to see a little bit of leveling out of some of the excellent results that have been out there, when more people who maybe aren't the creme de la creme of endoscopists like yourself doing these, they may not be as effective, and we may start to see more complications. So I think that these procedures add to the armamentarium, and overall they will make our population healthier and allow people mechanisms to lose weight. And honestly, ultimately, that's going to be less of a burden on our healthcare system, because by reducing weight, we know that it reduces healthcare costs. And honestly, if we don't make some kind of intervention, it's going to continue to go out of control. So that's where I think these all play in together. And then also thinking about it as cancer care, right? You try one treatment, you try another treatment, and people do that already, right? They try Jenny Craig, they try Weight Watchers, they figure out the one that works the best for them. And so these give patients alternatives to try different things. And then we might also come up with like a neoadjuvant therapy and adjuvant therapy. Try these before you have surgery, and then these are going to help you maximize your benefits from surgery if you start to regain any weight. So
fantastic. Thank you, Lena, for that answer. The other question that came through the chat, which is a relevant one that for the audience, is people are asking, what's the current state and understanding of gastroesophageal reflux disease with sleeve gastrectomy? Are we worried? And how is the mitigation approach for GERD in the setting of sleeve gastrectomy?
Well, as you both know, this is one of my favorite topics to talk about. So I could talk for days, but I'll give a shorter answer. First of all, yes, GERD after sleeve is a thing. It's something that we have to acknowledge, that we're taking one problem and maybe creating another. But as I had alluded to in my talk, I think that we're making better sleeves today. I know I myself make a better sleeve today than I did in 2009, and a more consistent sleeve. So I think that the amount of GERD, and we're actually writing this up right now, we just presented it at SAGES, that the sleeves that we're making now, we're seeing less GERD and more consistency of sleeve morphology than we did a decade ago. So we are making better sleeves, and therefore we're seeing about half the number of patients needing revisions for GERD. And this is at 3-year follow-up. So from the most recent cohort. So I think that GERD is going to continue to be a thing. I think that the restrictive only procedures over time, whether it was the bypass or the VBG, the band, and now the sleeve, have all shown that they have a higher revision rate than the malabsorptive restrictive procedure, which is the gastric bypass. And so that is something that we should acknowledge as a community. So, you know, a lot of things to think about there, and definitely want to take it into account and screen our patients before the sleep. If they come in having terrible reflux, well, then think about the fact, do they have a hiatal hernia? Do they have a dysfunctional LES? Because that's not going to change if you do a bypass versus you do a sleeve, right? They're still going to have a dysfunctional LES and a hiatal hernia. So let's think about what do we think about with reflux for people who don't have bariatric surgery? We think about hiatal hernias, we think about the LES. So we should be thinking about that in our bariatric patients as well.
Awesome. Well, I'll give you one more question, Lena, then we'll switch to Dr. Gerapino. And the final question is, if you have a crystal ball, you elegantly demonstrated the power of the GI tract to treat obesity and metabolic disease. But if you have a crystal ball, what's the wave of the surgical interventions of the future? Are we going to see more anatomy preservations, procedures that are along the surgical line? What do you see coming down the line as far as innovations in bariatric surgery?
I honestly think, you know, we're trying to get more or less and less, I guess is the way to say it, less and less invasive, right? I mean, there are beautiful technologies coming out like magnumoses and various technologies for us to be able to do a bypass with less morbidity, so to speak, and less technical surgical expertise and endoscopic expertise, right? So why wouldn't a patient want to have their bypass done endoscopically if they can do it without any incisions, for example? You know, these are the things that are coming down the pike, and then combining these minimally invasive techniques with medications and really focusing on multimodal therapy. And then thirdly, I think the big thing that we're going to find is that everybody has a different weight loss profile, right? So some people do well with intermittent fasting, some people do well with an Atkins diet, some people do well with bypass, and we have a lot of sleeves or actually lose as much weight as their bypasses. What makes all these people different? Okay, it's not just that some people exercise more and eat better, but I think that we're also going to find that there are some metabolic issues and maybe some genetic things that we can genotype, phenotype people into these various treatments to find the best treatment for that particular patient.
Well, it's been fantastic insights. We appreciate your time very much and your expertise, Dr. Ketan. We learned a lot. Feel free to drop, and we're truly appreciating taking your evening and sharing it with all of us.
Thank you so much for the privilege and the opportunity. Great to talk to all of you, and great to see you, Barham and Sai.
Absolutely.
Great to see
Dr.
you.
Gerapino, now the focus on you. We have multiple questions, actually, interesting questions. There's a lot of interest in the differentiation between suturing gastric remodeling and plication gastric remodeling. What's your thoughts about comparative safety and comparative effectiveness? Then we'll talk about the learning curve. Let's start with safety and effectiveness. When you say plication versus suturing, what's your thoughts on the matter? And the couple of questions in the chat were along the same line.
Yeah, from the data out there, from a safety standpoint, both techniques have similar SAE rate. We're looking at 1 to 2% SAE rate for both. So very similar. And when you look at efficacy, if you look at overall data, I want to say they are quite similar as well. We're looking at about 15 to 18% total weight loss at 1 year. We're very excited about the double helix technique, which is the most recent technique that we started doing about 4 or 5 years ago, because in our study, we showed 20.3% total weight loss. So is it possible that we're pushing the limit from 18 to 20%? Possibly, but that is one study so far. So I think we need more studies to look at that particular technique. But if you look at all, let's say if we do a meta-analysis of both ESG and POST, we're looking at similar efficacy as well.
So then with that in mind, how do you choose or how do you counsel your patients if they're saying, I want a procedure, and now you have these options? How do you counsel your patients at the current stage?
Yeah, so usually one of the questions that I would ask the patients, or maybe they will raise it themselves, is reversibility. Sometimes they want something that is reversible because they don't know how they're going to feel after the procedure. If that's the case, then we choose ESG because it's easier where you can go back and cut the suture and then kind of reverse the ESG. In contrast, post is harder technically, almost impossible to reverse the post procedure. Additionally, if patients had F3 to F4 fibrosis with NASH, we tend to use post over ESG as well. And this is all theoretical, but we think, let's say, if patients happen to have gastric varices, and we do all the workup to make sure they don't, but if for some reason there are gastric varices, by doing application technique, you're folding the tissue inward, so this way. And then you pass the needle and then pinch the tissue here. So then the gastric varices will not be bleeding outside. In contrast, if you do ESG, you fold the tissue this way. And then if the patients happen to have gastric varices, and then you hit the needle or pass the needle this way, if you hit the gastric varices, they might bleed into the peritoneum. So that is theoretically, but that is one of the algorithms that we use when we choose the procedure.
Thank you. And how about learning curve between plication versus suturing?
Very tricky question, and I will ask you back as well, Barham, but from my experience, it is easier to teach the post procedure compared to ESG to a brand new fellow. I feel comfortable walking the fellow through the first post procedure in patients. I can tell them, okay, push the blue button, pass the needle, and they can follow the command and they can do the technique okay. In contrast with the overstitch device, we would not let them start using the overstitch in patients. We will let them do it in a simulator first. So I think it takes a little longer for novices to get comfortable with the device. However, once they get comfortable with the device, I think it's more maneuverable. So you can walk them through how to perform a good stitch much faster with the overstitch. And in contrast for post, even though they can place plications, they can follow the demand, but I think it takes a little longer to figure out how to make a good sleeve with a plication device. So if you add the two things together, like get comfortable with the device and then get comfortable with making a good sleeve, I think overall it takes about the same amount of time, but it will be easier to walk them through the post in patients. In contrast, ESG, you would do it in a simulator first.
Thank you. Final questions before we have to wrap it for the evening is there's a lot of interest in combination of pharmacotherapies and endoscopic procedure, which makes a lot of sense. So, but obviously we need to be cognizant that we do not have an open check in the healthcare system to give everything, and we need to stratify and strategize what's the best cost-effective manner to do things. So as it stands currently, what's your best approach to adding pharmacotherapies to endobariatric therapies for obesity and metabolic disease?
Yeah, thank you so much for the question. So right now, we see the patients at 1 day, 2 weeks, 1 month, 3, 6, 9, and 12 months. And then we essentially graph their weight trend and see how fast they're losing weight. And let's say once they start slowing down with their weight loss, and usually that occurs between month 3 and month 6 for ESG and post, then we ask them, so number one, we'll look and see how much weight they have lost so far. If they're less than 10% total weight loss at that point, we offer adding an anti-obesity medication. Additionally, if they start to slow down and their BMI is still greater than 30, we also ask them and see if they're interested in adding an anti-obesity medication. So usually it ends up being somewhere between month 3 and month 6 after ESG or post when we offer an adjunct therapy.
Fantastic. Very insightful presentation, and thank you for all the answers for the question and answer. This concludes today's discussion and the question and answer session. As a reminder, the replay of this webinar will be available on the Endoscopy Now app within a few days, in case you would like to revisit some of the information presented by our brilliant colleagues with their extensive knowledge in this space. It will also be available on the American Foregut Society website, and we are thankful for both Endoscopy Now and the American Foregut Society for sponsoring this webinar. And thank you for joining us this evening. It was a pleasure. Thank you.
Thank you.